What were we talking about? We're talking about chest tubes, right?
Yeah.
So chest tubes, it's important to know that if you have a pneumothorax, it's just air. You put a small little pigtail in, it's less uncomfortable for the patients, and it gets the air out as long as it's in the right position, right? If you have, you want to make sure that it's up towards the top, because it could be that you drain the lung, but then the lung kind of closes around the chest tube. That's what happened, I think, with her. If you have a transudate, we probably should not be putting, and I don't think we should be putting, and the recommendation is not to put chest tubes in transudates, right? Because it's a problem of hydrostatic pressure, right? Really, you just have too much production. You have to treat the cause, which in this case is usually diuretics. So if you have a bilateral transudative effusion, what's going to happen is if you put the chest tube in, you're just going to be draining fluid continuously, right? Because you have to get the fluid out of the body, right? So you have to decrease the congestion and the hydrostatic pressure. If you have an empyema or a hemothorax, right? If you put in a small chest tube, then it won't drain very well. So the problem with an empyema or hemothorax is the inflammatory response will lead to severe scarring, and you'll scar the pleura and you'll form loculations. So loculations are hard because you have to get the tube in each pocket. And if that happens, then eventually you get a trapped lung. And that happens when the pleura gets so scarred that the lung can't expand, and that's loss of lung function that's usually permanent. And you have a window, right? Like if you have to get that junk out, the blood or the pus out, before this process has a chance to get scarred so bad that right? And there's this window, like 1 to 3 weeks or something, you really have to get this out. So if you have an empyema or a hemothorax, it's imperative that you get as much of that out of the chest as soon as possible. Okay? So now if you put in a pigtail on that, it's a couple problems. One is it's not going to be able to drain the volume, and two, it gets clogged very easily. Okay? And so it's not recommended to put a pigtail catheter in an empyema or hemothorax, but people still do. I don't know why. If you put in a big chest tube, 38-2, 36, even 28 French, those tubes, right, they're a little bit stiff. So one, they're bigger and they don't get clogged as easily, but two, that thing you put through, it pokes through the loculations and it moves a little bit and it'll break up loculations. Okay, so it's more likely to be successful emptying the chest and preventing long-term loss of lung function. What they do here is, for some reason, they always throw in the pigtail for everybody, right? And then there's delays, and they say, well, let's try TPA. And sometimes that works. But it's delays. And I've seen a lot of people who've lost, like, it's too late. You know, you send them to thoracic surgery, they're like, we can't do anything. Okay? So probably I think we should be putting in a bigger chest. Now, you can put in a big chest tube with a Seldinger technique. The exact same way you put in the pigtails. They have, you stick a needle in. It's very easy. You stick a wire up, and then you just do a sequential dilation, which is less painful for the patient, causes less air leaking. But we should be putting bigger chest tubes in those kind of things. Okay? So that's what we have to know about chest tubes. Now,